أهلا بيكم. Today we're going to study the temporal fossa. Um, and then we will proceed to the infratemporal fossa, of course. But we will start with this one today. Let's start. The temporal fossa is this area at the side of the skull. It's a space at the side of the skull with structures in it. So this is what we're going to study today. But first, let's take a look at the bones contributing to the region I'm describing. You can see this one. This is the squamous part of the temporal bone. Okay. You can see the greater wing of the sphenoid. You can see part of the frontal bone, a plate from the frontal bone, and you can see the zygomatic bone. All form the boundaries and floor of the infratemporal of the temporal fossa. We'll just take a look on individual bones. We will not study in details, but the details that's important for us that will serve the subject for today. For example, the temporal bone. This is a temporal bone. This is the lateral surface, left one lateral surface. This is the left temporal medial surface. It's composed of squamous part, this big part, scale-like, mastoid part, the one with the air cells inside, tympanic part, this plate that completes the external acoustic meatus, and an inner part. See this one? This is the petrous part of the temporal bone. The lateral surface of the squamous part forms the medial wall of the temporal fossa. It extends down till this crest. You see this crest? This is called the supramastoid crest. Descends down till this crest, supramastoid crest, and also you will find an impression of an artery, grooved by an artery called the middle temporal artery. It grooves the bone here as it ascends deep to the temporalis muscle. So this regarding part of the floor of the temporal fossa. What else? I want you to notice the mandibular fossa here. The mandibular fossa here, the one for articulation with the head of the mandible, and the articular tubercle, because they are at the margins of the fossa. See the mandibular fossa and the articular tubercle. Also notice the tympanic plate. The tympanic plate completes the external acoustic meatus and forms a suture that we will be dealing with in the infratemporal fossa, this region, later. It's called the petrotympanic fissure or petrosquamous fissure. The chorda tympani branch, remember the chorda tympani branch, the branch of facial, it comes out of the skull, exits skulls through this fissure called the petrosquamous fissure. But now we will be dealing with the floor of the temporal fossa. That's mainly by the squamous part of the temporal bone. Okay. Now this is the inferior part of the squamous temporal bone. See, it has a sharp. It bends sharply to the medial side to form what's so-called the inferior temporal or the infratemporal crest. Infratemporal crest. Remember this term, the infratemporal crest, hidden here by the zygomatic arch. This is the lower boundary of the temporal fossa as well. Okay. For the sphenoid, sphenoid means a butterfly. See, it has a body. It has foot processes, the pterygoid processes. And each pterygoid process is from medial and lateral plates, medial and lateral plate of pterygoid. See, this is front view of the individual bone. All this is the greater wing. See how it goes horizontally, laterally, then sharp turn upwards to form the medial wall of the temporal fossa. Here we are in the temporal fossa at this side, but here we are in the infratemporal fossa. So actually the greater wing of sphenoid, remember, it forms the roof as well as roof of the infratemporal fossa and the medial wall of the temporal fossa. Okay, I want you to remember this for future use, the foramen rotundum, the pterygoid canal, because in this area, in front of these two foramina, is the pterygopalatine fossa, the one we will study after the infratemporal fossa, okay? Just to be oriented. Notice, observe the lesser wing of the sphenoid. This is the lesser wing. And between it and the greater wing is the superior orbital fissure. This is the superior orbital fissure. Observe also the spine of sphenoid. It has a structure attached to it in the infratemporal fossa. Also, the sphenoid bone, but we will not be dealing with today, but it's worthy of mentioning since we have the this specimen. See, the sphenoid bone, the greater wing, has the foramen ovale and foramen spinosum in it. These are multiple choice questions. The foramina belong to which bones? Okay, I encountered many of these questions. The foramen ovale and foramen spinosum are parts of the greater wing of sphenoid bone. Okay, of course we can't see them in the front or the back. We only can see them from the inferior or superior aspect. This is about the sphenoid bone. So we learned that the greater wing of sphenoid forms part of the medial wall of the temporal fossa. Now what else? See this is the zygomatic bone. See, it has processes like, for example, this is the frontal process of the zygomatic. This is the temporal process of zygomatic, to articulate with a zygomatic process of the temporal. This is a maxillary process. See, it's rather rhomboid in shape. Now if you appreciate depth here, there is a depth here anteriorly formed by a plate from the frontal bone and the back of the frontal process of the zygomatic bone. Actually, this is the anterior boundary of the temporal fossa. I also want you to observe the zygomaticofacial foramen here. Zygomaticofacial vessels and nerves emerge from this foramen. We have a foramen like this at the back of the frontal process of the zygomatic called the zygomaticotemporal foramen. So we have zygomaticofacial at front and zygomaticotemporal at the back. And since it's at the back, so it's part actually of the temporal fossa. Okay? Now you understand the region we are talking about. The frontal bone, we said it shares with a plate that forms actually is forming the lateral wall of orbit, and at the same time from the back it forms part of the anterior wall of the temporal fossa. So the frontal bone has a share in the fossa. Okay, now observe this meeting of sutures. See, this is the squamous part. This is the greater wing of sphenoid. This is the frontal bone with a suture common with the parietal bone. See this H-shaped? Now there is a suture here between the parietal and the greater wing of sphenoid. So this is an H-shaped area. It's called the pterion. Starts with a P, but the P is silent. Pterion is of clinical importance because it's a landmark for the division of the middle meningeal artery at the inside. Injuries at this area may damage the middle meningeal artery and cause what's so-called the extradural hematoma. We will talk about this later, of course, when we come to study the cranial cavity. Okay, but just to be sure that since this is in temporal fossa, so we should observe it today. Okay, the terion in the floor of the temporal fossa. Okay, now the boundaries of the temporal fossa. Superiorly, you see these two lines? These are called superior and inferior temporal lines. They are the superior boundary. You can go with them backwards till you reach the supramastoid crest. Okay, this is posteriorly. Now, anteriorly are the plate from the frontal bone as well as the frontal process of the zygomatic bone. See, this is the anterior wall. And below, laterally, is the zygomatic arch. Medially is the infratemporal crest, we said, and then it communicates. See, we are here. It communicates medial to the zygomatic arch, lateral to the infratemporal crest, which is this one, with the space I'm in right now, which is the infratemporal fossa. Okay, the infratemporal fossa. So these are the boundaries. Of course, the lateral wall is the temporal fascia covering all the area, and the medial wall, we studied it and the features on it. Remember the groove for the middle temporal artery grooving the back of the floor here. Okay, the contents of the temporal fossa. First of all, there's temporal fascia. Then underneath the fascia, you'll find the temporalis muscle. And here, the zygomatico-temporal branch of nerve is coming out from the zygomatic bone, from branch of maxillary, and the zygomatico-temporal vessels from the lacrimal coming out of this foramen too. We have deep to temporalis, we have deep temporal nerves, we have deep temporal artery, and we have a middle temporal artery as the contents of the temporal fossa. It's an easy region to study, and it's a good topic for multiple choice and essay as well. Okay, the temporal fascia. If you have here superior and inferior temporal lines, which one will you stick the fascia to? Of course, the superior one, because it covers everything. Remember, the superior temporal line to the temporal fascia, and the inferior temporal line actually for the temporalis muscle, the one you see here. Okay, temporalis fascia is fan-shaped. It's tough, attaches to the margins of the temporal fossa back to the crest here, and then ends by attaching to the zygomatic arch. Some sources consider this as only a halt or a stop at the attachment. Then it continues as the periosteum of the zygomatic arch. Then it continues down on the masseter as the masseteric fascia. You may find this opinion in any of the books. But anyway, it stops both ways. It stops on the zygomatic arch. Okay, it encloses the contents of the temporal fossa, like the temporalis muscles, with the deep vessels and nerve. Okay, but remember, the superficial temporal artery, the superficial temporal vein, and the auriculotemporal nerve are on top of the fascia. They are not enclosed in the fascia. Okay, so the superficial temporal artery, the superficial temporal vein, this is the artery, this is the vein, and auriculotemporal nerve are on top of the fascia, means superficial to fascia, not deep to fascia. Remember, what's deep to fascia is purely temporalis and its blood and nerve supply. Okay, don't forget this point, please. It's a tough fascia, by the way, tough and thick fascia. You spend some time dissecting it. Okay, the temporalis muscle underneath. It's a fan-shaped muscle, as you can see. It's been described as in some sources as having anterior vertical fibers, middle oblique fibers, and posterior horizontal fibers, as you can see here. See, anterior part vertical, then it goes oblique until it becomes horizontal at the back. Of course, this change in direction of fibers will provide the muscle with a variety of actions. Means that the anterior and middle parts essentially for elevation of the mandible, but the horizontal part actually for retraction of the mandible. Okay, now the muscle converges downwards onto the coronoid process, and actually it's important to know the way it attaches to the coronoid process. First of all, it's part of MCQ. Second, just out of curiosity to appreciate the design here, it converges to the coronoid process of the mandible, attaches to the apex, posterior border, anterior border of coronoid process, medial surface of coronoid process, so I didn't mention the lateral surface, okay, and extends down with the anterior border of coronoid with the anterior border of mandible until it may reach the back area behind the third molar. See, it can go down till the level of the third molar. It has a good tight grip on the mandible, actually, the way temporalis is inserted. So remember this, the way of its insertion, that it doesn't involve the lateral surface of the coronoid, rather the anterior posterior apex borders and the medial surface, and continue down the anterior border of the mandible till you reach the level of the third molar. Okay, the action of the muscle, if you think about it, the anterior and the middle parts, essentially I said for elevating the mandible, and of course this means closing the mouth, and the posterior fibers for retracting the mandible. Retraction and protraction are movements occurring into the TM joint. Okay, the movements occur in the TM joint. The nerve supply of this muscle, actually all muscles of mastication supplied by the mandibular nerve. It has its own nerve coming out of the anterior division of mandibular nerve, as we are going to study it in the infratemporal fossa. I hope that was simple enough about this muscle. We mentioned the deep temporal arteries. Deep temporal arteries for the supply of the muscle come from the second part of maxillary artery. These are the temporal arteries, see? There's another artery coming out of the superficial temporal, this time, not from the maxillary. It's this one. It's called the middle temporal artery. Middle temporal artery comes out of the superficial temporal right in front of the ear. See, this is the ear cut here. Right in front of the ear, it pierces the lower margin of the temporalis muscle and appears on the deep surface of the muscle, actually grooving the bone. See, it's the one that grooves the bones while the others stick to the medial surface or deep surface of the muscle. See that? This is the middle temporal artery. What else in we talked about as a content? We talked about, or we mentioned the zygomatico-temporal nerve. See, this is the zygomatico-temporal nerve. See, branches here. It's apparent here. Okay, coming out from the zygomatico-temporal foramen, but it's cut, of course. Zygomatico-temporal nerve. So in these specimens, you can see the arrangement of fibers. You can see the middle temporal artery. You can see the deep temporal arteries. By the way, see these threads on the arteries? These are the nerves, the deep temporal nerves. These are the nerves coming out from the anterior division of the mandibular nerve. Okay. Muscles of mastication. We studied the temporalis. What's left is masseter and two pterygoids, medial and lateral pterygoids. Sometimes they are called internal and external pterygoids in American sources, but it's well known for being the medial and lateral pterygoid muscles. Now, before going further, we'll study the masseter muscle. This is the masseter muscle, see? At an instance, you can identify two parts. The superficial part, this one, and the deep part. See that? This is the deep part. They both meet and insert at the lateral side of the mandible. Now, the superficial part arises from the outer surface of the zygomatic arch. It may take from back of maxilla as well, reach as far forward as back of maxilla, then descends to insert itself at the lateral surface or the outer side of the angle of the mandible. It produces a very rough area on the angle of the mandible, opposite the insertion of the medial pterygoid from the inside. Okay, remember this. When you think about masseter, think about medial pterygoid. It's almost the same shape and components and the same insertion, okay? Parallel to the muscle, but from the inside. The deep part of the muscle comes from the medial surface of the zygomatic arch and extends down till the middle part of the ramus of mandible and may reach up high up to the coronoid process. So it inserts itself there. Of course, fuses with the superficial part. Now, it's important for the masseter to know the relations of the masseters. It's been a subject for questions. Remember, we said the parotid overlaps the masseter. Yes. Also, the parotid duct runs across the masseter with the transverse facial vessels above the duct, between the duct and the zygomatic arch means on the masseter, right? Remember, I told you the facial vein is superficial to the muscle, but the facial artery is anterior to the muscle. It's not superficial, it's anterior, where you can feel the pulse of the facial artery. Remember that. So the artery in front of the vein on top of the muscle, the facial vein. So we have facial vein, we have parotid duct, we have transverse facial vessels, we have accessory parotid lobules present around the duct, and we have the parotid itself. The facial process of the parotid itself covers the muscles. So it has relations to it, important to know. Okay, now this muscle receives its blood and nerve supply from the maxillary and mandibular respectively, by means of masseteric vessels and nerve. They come from the deep aspect, go laterally towards you, so they supply the muscle from the deep surface, not the superficial surface we are on now, the deep surface. How do they get to the muscle? Remember the notch in the ramus of mandible? Okay, the mandibular notch. It's for the passage, to allow for the passage of the masseteric nerve and vessels. So masseteric nerve and vessels pass through the mandibular notch to end by supplying the masseter muscle. Okay, it's a very powerful muscle. It's a tough muscle. Another thing about the action, since it goes obliquely backwards, it goes downwards and backwards, not straight downwards. It adds to the elevation function that it can assist in protracting the mandible, pulling the mandible anteriorly. So it will be the antagonist together with the lateral pterygoid that we'll study later, it will be the antagonist for the horizontal fibers of temporalis. If you're asked about the antagonist muscle for the horizontal fibers of temporalis, it's the lateral pterygoid and masseter, and medial pterygoid as well, because medial pterygoid also assists in protracting the mandible. See, so one retractor and many protractors for the mandible. Okay, it provides a very high bite power, by the way. It's, I think it's around 165 pounds per cubic centimeter. Remember that the jaw of the hyena provides 1100. We are only 125. They're 1100 pounds. The alligator is for 3,000 pounds per cubic centimeter. Okay, you study this with the TM joint. The TM joint, TM joints are joints between the mandible and the skull. The articular surfaces are the head of the mandible and the mandibular fossa plus the articular tubercle. Mandibular fossa plus the articular tubercle. Remember, articular tubercle and the mandibular fossa. These are the articular surfaces for the joint. The joint formed here is synovial joint, means it has a capsule, it has synovial membrane and fluid, it has ligaments, okay? But it differs than the typical synovial in that the articular surfaces are not covered by hyaline cartilage like other joints. No, articular surfaces are covered by fibrocartilage, other than the fibrocartilaginous disc that you see here. This big disc, see that big disc? This is the fibrocartilaginous disc inside the joint, which actually separates the joint into an upper compartment and a lower compartment, and observes it fits for the shape of the head of mandible. So the head of mandible actually is transverse, not anteroposteriorly elongated. No, it's transversely from side to side elongated. And actually, believe it or not, that was a question about the head of mandible, whether it's anteroposterior longitudinal axis or the transverse longitudinal axis. It's transverse. See, occupies all this area. The upper compartment is mainly for the protrusion and retraction of the mandible. And observe, if you protrude the mandible, you will push it against the articular tubercle. So actually the head will go down and forwards. Down and forwards. Actually, you're when this happens, when the head comes forwards, means the jaw is opened, opened at maximum, and descends down and forwards to keep it away from neck structures. So as when you open your mouth, you don't hit neck structures with your mandible. That's why it goes forwards with protraction. The opening of mouth involves protrusion as well as depression of the mandible. Now the inferior compartment is for the elevation and depression movements. Simple hinge-like elevation and depression movements, okay? So inferior compartments mainly for elevation depression movements, and of course the side-to-side movements as well. And the superior compartment is mainly for protrusion and retraction movements. You expect that there's the muscle that will protract the mandible. The main protractor of the mandible, which is the lateral pterygoid, attaches to the capsule and through it to the cartilaginous disc to pull it forwards. as it acts on the mandible, so that the articular disc doesn't crumble when the head of mandible goes down without it and returns back. See, it's a beautiful design. Okay, it's a very tough joint, by the way, and I told you about the bite strength provided by this joint. The capsule of the joint is attached around the articular margins. Of course, like any synovial capsule. By the way, it's a synovial of the condyloid type. Condyloid type, okay? Synovial condyloid type. What else? The capsule around the articular margins and lined by synovial membrane, which encloses synovial fluid that lubricates the articular surfaces of the joint. Now, I told you about the disc. Remember that it's made of fibrocartilage and it's attached to the inside of the capsule, and actually some sources mention that the lateral pterygoid attaches to it as well. Some sources say no, just to the capsule, but the lateral pterygoid attaches to the capsule from the outer side. See, and the other sources say that there is a direct connection between the lateral pterygoid and the fibrocartilaginous disc you find here in the mandible. This is the left temporomandibular joint. This is the ear. Okay, this is the maxillary artery. This is the superficial temporal artery, the left one. Okay, see the attachment here of the lateral pterygoid to the disc. See, to pull it forward so as not to crumble when the mandible goes back in its fossa, and because we need to protrude the mandible as well, okay, for wider opening of the mandible. Now, for like any other synovial joint, it has ligaments, extrinsic ligaments. They are not they are not capsular thickenings, they are extracapsular ligaments. First ligament is the lateral ligament. See that? It's attached to the tubercle, articular tubercle, on the lower part of the zygomatic process of the temporal bone, and descends down backwards. That was asked before. Down and backwards till the neck of the mandible. See? Descends down and backwards till the neck of the mandible. Exactly. Now, another two ligaments, they don't have to be right on the joint, you know. You know the ligament belongs to a certain joint that when you, if you remove this ligament, the joint will be dislocated. Okay, so this means that the joint, that ligament for that particular joint, like the ligaments we see here. See, this is the spine of sphenoid, and the lingular process of the mandible that guards the mandibular foramen attach the sphenomandibular ligament. The sphenomandibular ligament is a ligament for the TM joint. Okay, what else? We have a thickening in the capsule of the parotid, but from the inside, actually a thickening of the deep investing layer of the neck, because I told you before that the parotid capsule is part of the deep investing layer of the neck. So the inner part is thickened into a ligament that stretches between the styloid process and the angle of mandible. So give it a name, stylomandibular ligament. Okay, we can't say, for example, stylohyoid ligament is a ligament for the TM joint. No, it has nothing to do with the joint. Okay, see, this keeps the mandible up, as well as the sphenomandibular ligament keeps the mandible up, means the articular surfaces are articulating. Actually, they are not separated. Okay, All muscles of the that move the the temporomandibular joint, is supplied or are supplied by the mandibular nerve. Okay, so today we started with the temporal fossa and we studied the contents, and we studied a couple of mastication muscles, the temporalis and masseter. Next time we will go deeper and start with the infratemporal fossa, and we will continue the complete the muscles of mastication by studying the medial and lateral pterygoid muscles. Thank you very much for watching.